Hola, buenos días a todos y a todas y bienvenidos a esta masterclass sobre anosognosia en pacientes neurológicos y psiquiátricos de la mano del doctor Daniel Mogravi. Voy a empezar con una breve introducción y voy a presentar también, por supuesto, a nuestro ponente hoy. Primero, bueno, el tema de la anosognosia, ya sabemos todos que la anosognosia se define como la falta de autoconciencia o la falta de percepción de las propias limitaciones, de los propios déficits, tanto cognitivos como funcionales, en diferentes pacientes neuropsiquiátricos, en personas con diferentes patologías y enfermedades. Es un tema relevante y que tiene muchas implicaciones clínicas, importantes implicaciones clínicas, sobre todo de cara a la intervención y también afecta, como os podéis imaginar, al progreso de la enfermedad y al bienestar tanto de los pacientes como de los familiares, como de los cuidadores. Es un tema al que, bueno, los que me conocéis, aquellos de vosotros que habéis estado en alguna de mis clases también, sabéis que yo también suelo prestar especial atención a esta condición, al tema de la anosognosia en diferentes enfermedades neurodegenerativas, como es la enfermedad de Alzheimer. También suelo citar los estudios del propio Daniel Mogravi y su equipo sobre este tema y algunos de los descubrimientos que han hecho en este ámbito. Y voy a presentar al doctor Daniel Mogravi, quien ha obtenido el título de psicología, del grado de psicología y de máster en psicología, también por la Universidad Federal de Río de Janeiro, en Brasil. También ha realizado su tesis doctoral en psicología y neurociencias en el Instituto de Psiquiatría, Psicología y Neurociencia por la Universidad King's College de Londres. Actualmente es profesor asociado en la Pontificia Universidad Católica de Río de Janeiro. También trabaja como investigador visitante en la Universidad King's College de Londres. Su principal área de interés y de investigación, como he mencionado antes, es la autoconciencia en poblaciones clínicas, en pacientes con diferentes enfermedades clínicas y bueno, con diferentes enfermedades neuropsiquiátricas. Utilizan diferentes métodos para explorar, para estudiar este tema de la autoconciencia en pacientes tanto neurológicos como psiquiátricos. Desde el año 2016 hasta el año 2019 ha trabajado como investigador, ha recibido la beca Newton Advanced Fellow de la Royal Society and Academy of Medical Sciences de Reino Unido. En el año 2019 ha obtenido el premio de Early Career Awards de la Sociedad Internacional de Neuropsicología por su contribución a la investigación en el área sobre las relaciones entre cerebro y conducta. Y dicho esto, y ya sin más dilación, le voy a dar la palabra al profesor Daniel Mogravi, quien nos va a hablar sobre el tema de la anosognosia en poblaciones clínicas. Y bueno, decir también que es un verdadero placer poder tenerle aquí hoy con nosotros hablando sobre este tema tan interesante. Deciros también que los últimos 5 o 10 minutos de la masterclass se van a dedicar sobre contestar posibles preguntas que tenéis, preguntas que le podéis hacer a Daniel, las podéis escribir en el chat, las podéis hacer tanto en español como en inglés y nosotros os ayudaremos con la traducción si es necesario. Gracias.
Many thanks, Elena. It's a pleasure to be here with you guys. I'll be giving this class in English because I didn't want to speak in Portuñol, and I hope you can understand me. I have a few slides that I'm going to share with you now. The idea is to go over my presentation covering important concepts in relation to self-awareness or anosognosia, and also showing research that has been done into this topic. So to begin with, we'll talk a bit about terminology, about the words that I'm using here. And I quite like to use George Prigatano's term, impaired self-awareness. It's a very descriptive term, and it is used to describe awareness of self-ability, personal characteristics, including personality and also cognitive performance. I like this term because it's fairly broad and it can cover the many morbid changes that occur in response to a neurological or psychiatric disorder. But you may find other terms. Elena made reference to anosognosia. Anosognosia is used quite often in the neurological literature. So it's the term comes from Greek. So it's a form of agnosia, a lack of knowledge about condition noso. In the psychiatric literature, you have loss of insight used quite often. And I use both of these terms as well. So in some of my papers, I use anosognosia. In other papers with psychiatric patients, I use loss of insight. There is also another term that is used often, which is denial. Personally, I don't use denial that much because it implies psychological defense. And as we will see, that's not the case always. I think the only case that you can actually use denial with some confidence that the main factors are psychological is when you're dealing with oncological patients, for instance. So it's a population that has been investigated in relation to lack of self-awareness. Now, all researchers are going to say to you that their theme of research is the most important one. But in my case, that's actually true because self-awareness has been a quest for humankind. So we've been looking into self-awareness and trying to explore self-awareness since the beginning of our history. And I'm using here two examples, one from Western and another from Eastern civilization. From the cradle of the Western civilization in Greece, when you went to the Oracle of Delphi to learn about your future, visitants, they were greeted by the words, know thyself. So the message there is quite clear. In order to know about your future, you have to know yourself. It's in Greece, but also in the Eastern tradition. If you think about all the religions from the Indian subcontinent, you realize how important self-awareness is in this region, but also in the Far East. And bring here an example from Kyoto. Is the collection of shrines called Fushimi Inari, and then it's really beautiful. You go up a mountain. It's like it takes 3 hours to go up the mountain, going through shrines, and you go through the torii gates, those portals that they in the tradition they mean that you're going to another world, and then eventually when you're getting very near the top, you reach the shrine of Genrikyo Kami, which is a god of insight/sight. So people with eye problems go there as well. And it's very interesting because it's guarded by a fox. And we do know that self-awareness, although it probably exists across different animals, it is more developed in mammals. Of course, the fox is there because of the associations that we usually have. It's a shrewd, smart animal. But it's very interesting also this notion of going to the top of a place to reach self-awareness. And again, I talk about this to highlight how this is something that we've been dealing with since the beginning of humankind. And it's covered not only in religion, but also in art. And here I bring an example of Burns, the Scottish national poet. He tells a story in this poem of a lady who walks into a church and she thinks people are looking at her because her new hat is beautiful. But in fact, they're looking at her because her hat is covered with lice. And Burns writes, "Would some power give us the gift to see ourselves as others see us?" And this is a very interesting thing because one of the ways of developing self-awareness is seeing ourselves from an outside perspective. So when we see ourselves from an outside perspective, we may improve our ability to be self-aware. And this has been done in a number of studies, really. And it shows, I think, what is one of the problems of self-awareness, which is a matter of perspective. We're too close to ourselves to actually be able to see ourselves. So we need some distance. So perhaps that's one of the difficulties. I also like to use an example from sports, and that really very close to my heart, that one, which is how hard it is to actually be self-aware. It's not only a quest, but it's incredibly challenging. And my favorite example is this one because I'm Brazilian. This was written the day before Brazil played against Germany in 2014. And you probably can understand Portuguese. So why we're favorites against Germany? And there is this bit, which is my favorite bit. Brazil has the best defensive system in the world, and we know well the Germans. And that game was 7-1 to Germany. The interesting thing is that the journalist, he writes that the day uh, before the match was over, he's already writing about the biggest humiliation in the history of the national team. At no point he acknowledges, at no point he says something like, "Oh, by the way, I'm sorry. I thought that we had the best defensive system in the world." And that was the day before. And me being me, I developed a morbid fascination with the journalist's career, and now he's working in a field in which lack of self-awareness is quite rampant, which is science journalism. But that's not like to pick on him. It's just to show how hard it is to actually be self-aware. It's very challenging. It's very difficult. It's very hard for us to have a measure of ourselves. Okay, why do I study this? It's incredibly important, as Alina said at the very beginning, it's incredibly important from a clinical point of view. So we know that it affects treatment compliance because if you don't know you have a problem, why would you treat yourself? And we published a study with Spanish colleagues, Bernardino and Israel, showing how rehabilitation, neuropsych rehab, does not work well when you are unaware. And that was in people with Alzheimer's disease. It's also linked to patient safety because you expose yourself. If you believe you're capable of doing things you're not capable of, you expose yourself to risky situations. And also a main factor in caregiver burden. It's already very hard to take care of someone with a condition. If this person is not even acknowledging difficulties, it becomes harder. And socially, it's also linked to an increase in care costs. So, in terms of clinical implications, it's quite vast. So, what is our research strategy then? We do know it's clinically relevant. And how do we proceed? We begin by doing theoretical modeling. And I had the pleasure to be co-author of the last version of the cognitive awareness model, which was initially developed by my PhD supervisor, Professor Robin Morris. So the notion behind the model is that anosognosia or lack of awareness can be quite heterogeneous. So you may have similar presentations, that is, a person not being aware, but the causes can be vastly different. And now I'm going to talk about that, different causes for that, and then try to show how empirical evidence supports this heterogeneity of anosognosia. So we can begin by focusing on some elements of the model, and there is a whole part of the model which suggests that unawareness can be mnemonic in nature, it can be linked to memory function. So perhaps people, when they have memory impairment, they cannot remember how well they can do things. And we captured this notion in a paper that we published many years ago, which was called Anosognosia in Alzheimer's disease, the petrified self. It was an analogy suggesting that maybe people with Alzheimer's disease, they have this sense of self, which is solid, but outdated, and which cannot change through time because of lack of memory consolidation. So that was the analogy there, the stone analogy. And last year, we had the pleasure to publish a review discussing this framework 10 years after the initial publication and showing it. And it's really nice when you do that, when you suggest an idea and then empirical data vindicates the idea, suggests that you were right, including data from other researchers. So we showed that in this paper last year, indicating that indeed there is some very consistent evidence for mnemonic anosognosia. So what is this phenomenon? I think in the case of people with dementia, it has two sides. As I said, lack of update of personal ability. So because of the memory impairments, people with dementia, they cannot update their sense of self. So that's a study from Annalena Veneri's group, and essentially they show that before a test, you ask people with Alzheimer's disease, how are you going to do the task? And they tend to overestimate. Performance is here in this line, okay? The actual performance. So the pre-test estimation, it's an overestimation. Once people do the test, they become more realistic. They realize, whoa, didn't do that well, the task. But then after a delay, half an hour delay, they get back to pre-testing level. So they reset their expectations because the information is not available for them anymore. They cannot update personal ability. And that has been shown by other researchers as well. So the work by Chris Mullen and his group showing how different types of memory rehab and memory training can be affected by that. So the first trial, the closer to zero, the more realistic you are in terms of your accuracy of memory estimation. So first trial, people with Alzheimer's disease, they're not accurate at all. And then in the following trials, they become more realistic. And then you have a second visit. It's a week after the first visit. Again, they reset their expectations. And we have done work on this as well by Anna Fisher, and I'm going to show some of her other data later on. This was a paradigm in which we use EEG, but there was the behavioral data, which was quite interesting. We asked for estimations over 10 trials, 100 trials, and 500 trials. And what we found was that in the short term, there's no difference between people with dementia, older adults, and young adults. But when you have a larger number of trials, then the information is not available anymore. And people with dementia, they become less accurate, supporting this notion of mnemonic anosognosia. The other element of the equation is not only lack of updating, so the anterograde memory impairment, but also the retrograde memory impairment that you have, the graded memory impairment that you have in people with dementia. So there is this very standard curve when we think about autobiographical memory in the general population. So we remember a lot of stuff which is recent, and that happens with a number of memory paradigms, not only autobiographical memory. Then we have a reminiscence bump. We have quite a few memories from late adolescence and early adulthood that help to create your sense of self. And then we have also infantile amnesia, so we don't remember that well about stuff that happened in our first years of our life. What happens with people with dementia is that they don't have the recency effect. Again, because of damage to the hippocampus. So this is a study by Sergio Starstein. And in that study, he followed up people with Alzheimer's disease for 18 months. And what we can see is that even in the baseline, there is poor memory for recent events. So essentially, people with Alzheimer's disease, they're relying on older memories, hence the idea of a petrified self as well, something which is older but solid. And when you take a look at the follow-up data, it's almost like the lines are in parallel. The lines are very similar. You have a general reduction of memory ability with progression of dementia. But generally speaking, again, people with Alzheimer's disease, they're remembering better stuff that happened at the beginning of their lives, especially adolescence. So you don't have the recency effect. And that kind of explains the analogy that we made. And again, in the past 10 years, more evidence has supported this notion. I mentioned that anosognosia is heterogeneous, so there are other factors that may be linked as well to lack of self-awareness, and one of them is what we call executive anosognosia. So in a few clinical groups or in a few patients, memory may not be the main issue. The main issue may be in error monitoring per se, difficulties in monitoring in metacognition. So for that reason, we postulate a comparator mechanism, or rather quite a few comparator mechanisms. And we investigate that. And I'm going to show some future studies that we're doing in relation to that. And again, there is some evidence in a number of clinical populations. In fact, I'm showing here Alzheimer's disease, but you have psychosis as well. So people with schizophrenia and many other clinical conditions in which you have some error signals, some ERPs. So this is sorts of stuff that we study with EEG. So you have electrical signatures in the brain that respond to errors. So and that respond both to correct trials and incorrect trials. You have the ERN, and when you compare the ERN across age groups and also with patient groups, you realize that some groups, they have an attenuated ERN, so they don't respond to errors as much as healthy people. And as I said, that happens with a variety of clinical conditions. Although it has been seen, for example, in OCD, people with OCD, they're over-responsive. But most clinical conditions, they're characterized by reduced responses to errors. And that can be measured, as I said, through electrophysiology. And we've done a bit of that, I'm going to show later, but more related to effective responding as well. The other feature of the model is what we call this metacognitive awareness system. And the notion here is that you may have mnemonic anosognosia, you may have executive anosognosia, but you may have what we may call primary anosognosia. Primary anosognosia because there is no other cognitive factor which is driving that. And there are different ways to think about this phenomenon. We know there is no awareness center in our brains. It doesn't exist. But we can think about awareness either in terms of connectivity between regions, but also in terms of how psychosocial factors give visibility to some features. So that's how we explore the issue of primary anosognosia. I had the pleasure to take part in a study in which we use epidemiological data. So to date, I think it's still the largest study on awareness in dementia with almost 900 people. And essentially what we were able to do is compare awareness of memory impairment across countries. And we had data from 3 world regions, was China, India, and Latin America. And all those participants had memory impairment because it was one of the diagnostic criteria. So 100% of them had memory impairment, and up to 72% presented with lack of awareness of memory problems. And this was higher in India. It was significant. And there was another issue that in another study we showed that in India, not only people with dementia were unaware of their difficulties, the caregivers were unaware as well. And that gives us a very strong hint there's probably something cultural, something about values in Indian culture that create this atmosphere in which both people with dementia and their caregivers are unaware of the difficulties more than in other regions. And talking with colleagues from India, there were a number of suggestions why this was happening. Maybe it's just broader social awareness. Maybe this was linked to ideas on health, very different system of medicine in India, in the sense that you have traditional alternative medicine as well, and ideas related to health that exist for centuries. And also the role of older people in their families. So maybe out of respect, people would suggest that difficulties were not as prominent as they were. So interesting to see how this phenomenon, we can go from EEG to cross-cultural comparison. So that's one of the things that really fascinates me about studying that, is that you can cut across complexity levels studying that. And that's exactly what I'm going to do now. It's like going from culture to neural networks, because as I said, primary anosognosia may also be linked to lack of connectivity. So it has been shown by the work of Perrotini and colleagues that this connection between memory regions and the frontal lobes may be behind anosognosia. So again, we were talking in a rather schematic way about mnemonic and executive anosognosia, but maybe there's something linking those two forms of anosognosia in terms of brain connectivity. And we did a study also with on brain connectivity, and that was using DTI, so structural connectivity, and we were able to show how in a number of different indexes, poorer connectivity was linked to higher unawareness. So people had lower awareness with poorer connectivity, indicating that awareness is a very complex cognitive ability that recruits a variety of brain regions, and that connectivity may play a very important role. Okay, there is another feature of the model, and again, the model here is just a way of creating ideas that can be tested empirically, and that was the main drive of my PhD. But this idea from the model comes from the observation of neurological patients mainly, who show signs of behavioral and affective adaptation to the condition despite an awareness. So these are people who say they're fine, but they comply with rehab, they remain in the hospital, they take their medication. They say their attention is preserved, but then they stop driving, or they recruit more co-pilots, or they restrict driving to familiar neighborhoods. So clearly, there is something happening there in which a dissociation between what people say and how they behave suggests implicit processing. And we call this implicit awareness. It's an oxymoron. It's if it's awareness, it shouldn't be implicit. That's why we called it implicit awareness, because we wanted to capture this apparent paradox that you have in those people. And my PhD, that was the main theme of my PhD, was exploring the implicit arm of the model. And I did this with computer tasks that were had a set level of difficulty, and I measure emotional reactivity. So essentially, what we were able to see is that both in people with dementia and controls, reactivity was similar in terms of self-reported emotion and facial expressions. Um, but metacognition was different. Awareness of performance was quite different. The controls, they underestimated performance for both success and failure. But with the people with Alzheimer's disease, they overestimated their ability in failure, but they underestimated in success. This was very interesting to show because it indicates that it's a neurocognitive factor in operation. If it was something like denial, then they wouldn't underestimate success. So it shows it's not psychological in nature, but rather it's something that is neurocognitive. And we were the first to actually show that in people with dementia because we had those computer tasks and we exposed people to success. No one had explored awareness of success in dementia. And by definition, people with dementia, they don't do very well on cognitive tests. But because we had a computer task that control for the difficulty, we're able to see that. So that's a very interesting feature. The other interesting feature is that I think also was the first time that we were able to control for performance in both a patient and a control group, because typically the patients, they don't do as well. So that's a bias in the data in terms of the estimation. But because of the computer tasks, the performance was the same across groups. And all the variation was due to lack of self-awareness. So interesting to see how, despite showing poor awareness of how well they're doing, the emotional reactivity is normal, is preserved. Typically, I show a video of the patients, but because this is going to be on YouTube, I'm not going to be able to do that. But the interesting thing to say is that this reactivity to this emotional reactivity did not correlate with awareness. So we had people who were deeply unaware of how well they did, but despite of that, they showed very strong emotional reactions to the tasks. But these emotional reactions, it's important to say, were within the limits of frustration doing the task. Okay, there was another issue, and that was the issue that took me to psychiatric patients, which is how we can think about mood how mood disorder may impact on self-awareness. And we know across clinical conditions that depression is associated with more preserved self-awareness, at least if we're talking about awareness of ability. So that happens in AD, in TBI, in psychosis. And we also know that apathy is linked to reduced awareness. So what may be happening here, again, we go back to the model, we zoom in, we create something that can be a hypothesis that can be tested. Perhaps apathy is linked to reduced awareness because you have effective blunting. So you make an error, but you don't react that much to the error. That's the potential explanation. And in the case of depression, there may be many different explanations: depressive realism or negative bias, which is influencing how people express. So someone who's depressed may say, "Oh, I'm not very good at that." They may look like it's awareness. How people represent experiences, so they may focus more on errors, or how they remember experiences. So you may have a mood congruent effect in which people who are depressed remember more negative things, including that they didn't do well in a task. In order to explore that, we decided to investigate bipolar disorder because it's a natural experiment on self-awareness. So in bipolar, you have fluctuations of insight or self-awareness in the same person following mood fluctuations. We did a variety of studies. This is one of my favorite ones. It took us over 2 years to have 48 people with bipolar, and they were evaluated at the four possible mood states that you have in bipolar: euthymia, depression, mania, but also mixed state. And we evaluated their insight with classic psychiatric questionnaires. And what we were able to see is that in euthymia, you have preserved awareness. You know you have a condition. You know you have bipolar. In depression, you also have preserved awareness. In mania, you lose your awareness. You lose your insight. The higher the score, the higher the loss of insight. But in the mixed state, you also lose awareness. We thought that the mixed state would be in between. That was not the case. It shows that just a bit of mania is sufficient for you to lose awareness. If you have the psychomotor acceleration and agitation of mania, then you lose awareness. We also investigated whether previous history affected that. So for that, we got over 100 patients with bipolar disorder, and then we divided them according to polarity. So polarity in the study of bipolar is occurs when someone who has bipolar has more than 2/3 of episodes in a certain direction. So if you have more than 2/3 of your episodes as mania episodes, then you have manic polarity because your bipolar disorder manifests itself more as mania than depression. So essentially, we had patients in euthymia and in mania, and they could have either undefined polarity, so a balance between episodes, or manic polarity. And our main interest was: is the manic polarity going to push people towards loss of insight? And we found that it didn't have an effect. It was actually current mood state and not previous history. It didn't really matter the number of previous affective episodes that you had or your predominant polarity. What really mattered was, okay, how's your mood state now? If you're in mania, you have loss of insight. It's very interesting to do that with people with bipolar because, as I said, it's a natural experiment. But you can have even more statistical power with a natural experiment, manipulating variables. And that's what we did. That was the work of Elodie Bertrand, who did her PhD and postdoc at the lab, and now is a lecturer at the University of Paris. We did an experiment on mood congruent recollection, and essentially people with Alzheimer's disease had to do a tough task or an easy task. There were no differences between mood state before each task, but then for the reaction time tasks, after doing failure tasks, people got frustrated, as you would imagine. So their emotional reactivity became more negative, so more negative effect. But there was no change in awareness. We were thinking that maybe if we get people a bit frustrated with tasks, they're going to remember that they have difficulties. So no change here. But with memory tasks, again, people get a bit frustrated, and then their awareness improves. And I think that's a really interesting result because it shows to us It's not only a matter of mood congruent recollection or mood dependent recollection, but also of context dependent recollection. It's not failing in any task, but failing in something which is core to their clinical condition, in that case, memory. And that was why we had reaction time and memory, because reaction time is something that you lose with age in general, but memory is more restricted, or is the core diagnostic feature of dementia. And also in that study, we were able to show how changes in anosognosia, they correlate negatively with apathy. So those who were apathetic, they didn't react to the task, and then they didn't have the improvement in self-awareness. So that's very interesting. And that also links to work done by Anna Fischer, who now is a postdoc at Göttingen University in Germany. So she investigated with ERPs, emotional reactivity in people with dementia. She was able to show how feedback-related negativity, which is an ERP linked to emotional reactions to error, how this is affected in people with AD, with an attenuated signal here as well. And then what we do, we get back to the model, we come up with ideas, and we create more experimental work that at the end of the day is done to improve people's lives in clinical practice. So we're publishing now some articles on autobiographical memory, metacognition, and insight in bipolar disorder, ERN and LPP, which are some ERPs used for both error monitoring and emotional reactivity. And also we're now doing work with oncological and neuro-oncological patients. So trying to see if the comparator mechanisms, they're specific to a cognitive domain. We cannot do that in dementia, because in people with dementia, you have global damage, global atrophy. So we're starting to do that now in neuro-oncological patients where the damage is more focal. You can take a look, okay. What is the difference between a frontal and a temporal tumor? And also comparing denial and anosognosia in oncological versus neuro-oncological patients, because then we can have a control group for the psychological factors of cancer, which is general oncological patients, and compare those with neuro-oncological patients. And then we tease apart what is psychological there and what is neurocognitive. Well, that was it for me. I hope you guys have enjoyed. I also would like to thank not only you for your attention, but the participants and their families. They're the reason of our work. That's why we do that. All the collaborators listed here or otherwise, and the funding agencies without which we wouldn't be able to conduct our studies. And I'll be more than happy now to take a few questions.
Thank you very much, Daniel, for your presentation. It was very interesting to listen to you throughout your intervention. So now, I'm sorry. Ahora, si alguien tiene alguna pregunta que le quiere hacer al profesor Daniel Mogravi sobre el tema, ahora es el momento. Podéis escribir vuestras preguntas. Como he dicho al inicio de la masterclass, las podéis hacer tanto en castellano, en español, como en inglés. Y nosotros, si es necesario, os vamos a ayudar con la traducción. So in the meanwhile, while we're waiting, if there's any possible questions from the attendees, I have one question, Daniel, and it is true that it is related to the depression, right? To the depression states in the severity of the depressive symptoms in some patients, especially some patients with neurodegenerative diseases, because it is true that the metacognitive system, the metacognitive awareness system, and its preserved function has been associated with some milder depression or milder depressive symptoms, however, which is interesting, right? However, in some patients with some more severe depressive symptoms, there is usually an kind of inversely
Yeah.
cause self-underestimation, for example, in patients with Alzheimer's disease, right? So can you explain this a little bit, or can
Yeah.
you
No, that's a
what's your
really good
opinion about
question.
this? Yeah.
It's a very good question, and I used to be a bit more naive about that, and now I try to be more cautious in terms of saying how depression may be linked to self-awareness. I think what's probably happening there is some sorts of bias. It's either memory bias, as I said. It may be easier for you to remember things, negative things, when you're depressed, or just a reporting bias, or general negative bias. We do know that for other processes, depression does not help with self-awareness. So there is some evidence also about this relationship in the case of interoception. So if you have, I think, mild symptoms, it improves a bit, and then if you have more severe symptoms, it disrupts self-awareness. I think what happens in the cases of severe depression is that you have excessive self-reference, and that is something that you see when you see the functional imaging of the brains of people with severe depression. They're ruminating. So people who are ruminating, they're thinking about themselves all the time, and this is linked also with negative effects. So what I think happens in severe depression is that people, they get too fixated on themselves, and as I said at the very beginning, then you lose all sense of perspective. So you were stuck thinking, oh, I should have said something different, I should have done something different, or you're thinking about the future, anxious about the future. So my guess would be that maybe it's such an excessive self-reference. You become so self-referent that you lose perspective about yourself, and then your self-awareness goes down.
Yeah. Okay, yeah, it is true. So it might be related, right, to this excessive rumination that you have mentioned, this excessive
Yeah.
self-fixation. Yeah, thank you for sharing your opinion with us, which is something that I have questioned for some time now. And since you brought it up in your presentation, I wanted to hear your opinion about it as well. And I wanted also to ask you to finish the masterclass. I wanted to ask you, since you have mentioned some of the studies that you have published, that you have performed and conducted throughout the years, I wanted to ask you, as curiosity, out of curiosity, what will be the future lines of research in your team on the topic of self-awareness and anosognosia?
Okay, yeah. Well, the future research directions, they're quite diverse at the moment, because there are, I think, different lines of research that we were pursuing. And the beginning of my work in this area was with neurological patients and neurological conditions. So you have structural alterations in the brain leading to changes in self-awareness. Then I started to do some work in parallel with psychiatric conditions. Then you have functional changes in the brain leading to changes in self-awareness. And more recently, I've been starting work on psychoactive substances as well, because then you have something which is functional and reversible. So you can see how self-aware a person is, and then give a medication, a psychoactive substance, and then see the changes, and then see what gets back to normal. So that's one direction. And the other direction is expanding the notion of self-awareness. So we have a very important paper that has just been accepted last week, in which we do a taxonomy of self-awareness processes. Because most of my work was awareness of uh, metacognition or cognitive ability, awareness of condition, and now I've been expanding that to other constructs such as interoception, agency, emotional regulation. So these are the general directions we're going.
Okay, thank you very much, well, for your answer, and we'll be looking forward to reading those papers once that they're out, that they're
Yeah,
published, especially the one about the psychiatric drugs. And
yeah.
I will be looking forward for reading them. And there is one question also, Daniel, from Claudia Fuente. First of all, I will read it to you out loud. So first of all, thank you so much for your time and amazing presentation. Just wanted to ask, is there any correlation between neurodivergent people and memory loss or hardships with success to me? Okay.
Yeah, well, thanks for your question, Claudia, and the kind words. I must confess I don't know about any particular data on that. So if I understood correctly, you said success estimation and memory loss. I think, as I said, success estimation and memory loss, there is quite a lot of stuff. But I don't know other. And when you mention neurodivergent, I'm supposing you're also thinking about the autism spectrum, right? So if that's the case, I do know that there are a few studies on metacognition into autism. Selene Souchet has done a few of them. And I do know that it's a clinical group that has changes in self-awareness. Um, but the actual data is something that I don't know fully.
Okay, thank you. And another question which I find a little bit difficult to answer, which is from Bea. She says, what future do you think that there will be for diseases like Alzheimer's? Do you think that there will be that we will be able to evolve from that, or it will be an eternal burden for those who develop it?
It's a good and a
So,
tough question, Bea, but I'm fairly confident that eventually you'll be able to tackle the condition. It will take some time. Um, I think. I guess it will take some time, but I'm fairly confident it will eventually happen. In the meantime, I think it's about mitigating. So we have to search for interventions for people with dementia, but we have to mitigate the difficulties as well. So that's why neuropsychological rehabilitation and cognitive stimulation are so important. Working with caregivers, improving quality of life in people with dementia. So before we reach this horizon of a cure or of a treatment that is so effective that we actually can get rid of the condition, we have to work to make life better for those with the condition.
mm, thank you, Daniel. Yes, I do think that it's a tough question, right? And it is a question that a lot of people are asking in nowadays. I'm also confident about this, that there will be a cure someday, probably in the near future. We don't know, but yeah, it is true that the most important thing is to at least try to mitigate, right, alleviate the symptoms. And there have been an enormous progress that has been made in this direction. Okay, thank you very much again for your time. Thank you very much for the wonderful presentation. It was a
My
pleasure listening
pleasure.
to you. And so I don't know if we have time for one last question. Okay.
Oh,
So another question, yes, from
it's a good one. I
Raisa
can
Ruano
see.
Quesada.
Yeah. If it's
Okay.
beneficial to know about your own problem, right? And I just saw and disorder. Uh, Thanks for your question, Haisa. It's a really good question, and I've been asked that many times. I've been asked if it was something happening to you, would you like to know, or would you rather not know about your difficulties? We do know from the literature on cancer that people who are in complete denial of their condition, they have very negative outcomes because they don't engage in treatment, they don't help in any form of diagnosis and treatment. So that's something that is going to lead to a bad prognosis. So some level of self-awareness is relevant. Nevertheless, thinking about your difficulties all the time is not going to be helpful. So I think my question, or my answer to your question would be, um, some level is needed. To some extent, you need to know you have difficulties, but the more relevant thing, the most important thing, is to actually be able to adapt to your condition, be able to, in terms of your behavior, your affective regulation, to respond to your condition in an appropriate manner. If this is happening, if you don't know the actual label, if you don't know exactly what you have, but if you're complying with treatment, if you're helping others to take care of you, then that's fine. So it's not about knowing the label, it's not about thinking about the condition all the time, but having sufficient self-awareness that you can collaborate with others and with your own treatment.
Thank you very much again, Daniel. And thank you all for your questions as well and for your interest. I hope that you have enjoyed this masterclass, and I hope that you have learned, of course, some new things. Gracias a todos los que habéis asistido a esta masterclass. Espero que la hayáis disfrutado. Y gracias de nuevo al profesor Daniel Mogravi por su tiempo y por su presentación tan interesante y tan que nos ha proporcionado información tan útil, ¿no? sobre un tema tan importante.
It was my pleasure, Elena. Thanks for the invitation.
Thank you. Thank you, Daniel. Nos despedimos ahora. Muchas gracias de nuevo y nos vemos pronto.